And one more remaining will be MIGS in post-trab. How good in achieving targeted TOP? Vijay Kumar.
So good afternoon, sir.
Yeah, okay.
Thank you, sir. I'm Dr. Vijay Kumar. I'm going to present my study in post-trabeculectomy patients who underwent MIGS. So as we all know, glaucoma is a chronic progressive multifactorial optic neuropathy with intraocular pressure being the only modifiable risk factor. Usual treatment is with medical management with anti-glaucoma medications, then laser trabeculoplasty, and then trabeculectomy. And then in advanced cases, we can do tube surgeries. So with the last decade seeing unprecedented growth with minimally invasive glaucoma surgeries, we have started having good and reproducible results. Though trabeculectomy remains gold standard for treatment in advanced glaucoma, chances of failure is high at 5 years. Up to 40% patients with trabeculectomy have failed. Hence the idea of doing Migs in such patients who have failed trabeculectomy in achieving target intraocular pressure. The advantage of Migs being faster recovery, topical surgery with minimal or no pain, and no significant vision threatening effects. It's a retrospective study of 39 patients who had failed trabeculectomy surgery enrolled between December 23 to June 24 with the history of primary open angle glaucoma who underwent trabeculectomy with corrected IOP more than target intraocular pressures, who underwent either bent ab interno needle goniectomy, excisional goniotomy with KDB glide, or iStent trabecular bypass system. The patient at least had a 6-month follow-up post minimal invasive glaucoma surgery by the same surgeon. We excluded aggressive glaucomas like pseudoexfoliation, pigment dispersion glaucoma, uveitic and primary angle closure glaucoma, and post-vitrectomized eyes. Pre and post-operative gonioscopy was done in patients, and applanation tonometry at 1 week, 1 month, 3 months, and 6 months have been documented with an anti-segment OCT. We had 21 patients who had success post-Migs at 6 months. The patient never needed any intraocular reducing medication, anti-glaucoma medication, with target IOP being achieved. And 16 patients had partial success at 6 months. They need at least one anti-glaucoma medication to have achieved target intraocular pressure. And 2 patients actually failed the procedure, so they needed more than 2 anti-glaucoma medications to have controlled intraocular pressure. These are our results. And with a particular procedure, the success rate has been described in this slide. With MIGS bang, 54% had success, 46% had partial success. With MIGS iStent, 50% had success and 50% had partial success. With Migs KDB, 55% had success, 36% partial, with 9% failed. Failure was defined as persistent hypotony or IOP more than 21 millimeter or IOP not reduced to 20% of baseline. Traditional alternatives used to be bleb needling, repeated trabeculectomy or tube surgery. With advancement being Migs being more affordable than ever before, we tried Migs in these patients, and the success rate was IOP drop was 38% with bang and 35% with iStent, and KDB with 40%. Mean IOP reduction in all methods are comparable, with bang being the most affordable therapy. Conclusion: MIGS has proven to be a viable option in patients who had failed trabeculectomy. Our study found out that Migs done in India with KDB, iStent or bang produced comparable results with Zen implant done in US. Additional prospective studies with larger cohorts are essential to understand long-term efficacy and also late onset complications of Migs. The clinical significance of this study is, this is the first case series comparing 3 types of Migs and also the first study in India to be done under failed trabeculectomy. Thank you, sir. Yes, sir. Yes, sir. Yes, sir. Long terms we want. Yes, sir. Training required for the surgeon. That part is also very. Yes, sir. Yes, sir. Thank you. Thanks.